antiretroviral therapy, initiation, adherence, and retention in care, HIV care, in resource-limited settings, including clinicians, clinical officers, nurses, midwives, and pharmacists. The module will also be useful for facility managers, public health professionals, and community healthcare workers. It aims to enhance participants' capacity to provide evidence-based, quality, accessible HIV services based on the global normative guidelines from the World Health Organization. The module also summarises best practices and innovative approaches to maximise treatment adherence and to ensure people remain engaged in care. Retroviral therapy initiation and adherence. Much more to do. Globally, only 75% of people know their HIV status. 59% of people are linked to care and on ART, and 47% are virally suppressed. USAID's 90-90-90 targets will be met by 2020. However, 13 high-burden countries in sub-Saharan Africa are on track to achieving these targets. Here are 3 examples of Zimbabwe, Malawi, and Zambia. The percentage of people who are aware of their HIV status ranges from 67% to 74%. Of those who know their status, between 85% and 89% are on treatment, of whom 86 to 91% are virally suppressed. Here, ART substantially improves health, well-being and quality of life for people living with HIV. People living with HIV on ART can now have a near normal lifespan, and ART has sharply lowered AIDS-related mortality and morbidity. Antiretroviral therapy also reduces HIV transmission. In the Partner and Partner 2 studies, in which one partner was HIV positive and on ART and the other partner was negative, couples in the study had sex more than 58,000 times without using condoms, and there was 0 linked HIV transmissions from the HIV positive partner on ART to the HIV negative partner. In the Partner 2 study, 972 serodiscordant couples were enrolled and there were no linked transmissions. These remarkable results have given rise to the U=U movement, which means that if a person is on ART and undetectable, they cannot transmit the virus. Because it transforms the social, sexual and reproductive lives of people living with HIV. It enables them and their partners to be in a relationship without fear of transmitting HIV. U=U conveys an evidence-based message that people living with HIV who achieve undetectable viral load cannot transmit the virus. Talk to your patients about U=U and the necessity for staying undetectable for U=U to work, the importance of HIV treatment adherence to stay healthy and prevent transmission. Explain and reinforce that when HIV is suppressed, they cannot transmit HIV to their partners, and the importance of knowing their viral load so they and their partners are sure that they have an undetectable status. Into clinical practice as an essential component for increasing the uptake of HIV services. When people learn about U=U, they are more likely to get tested and to start and stay on treatment. Talk to people about U=U, counsel people on the necessity of staying undetectable for U=U to work. Educate people on the importance of taking medications every day to stay healthy and prevent transmission. Focus on when to start treatment and what to use in first-line therapy as recommended by the World Health Organization. This section will also address the use of dolutegravir by adolescent girls and women of childbearing age, that everybody who is HIV positive should start treatment immediately. The initiation should be offered to all people living with HIV. Rapid initiation is defined as starting treatment within 7 days of a diagnosis of HIV. ART initiation should also be offered on the same day to people who are ready to start treatment. Same-day treatment must in all cases be voluntary. Stated its recommendations for first and second line antiretroviral regimens. The new recommendations are based on evolving evidence of safety and efficacy and program experience on the use of dolutegravir in women of childbearing age and the use of efavirenz 400 milligrams in pregnant women and people co-infected with tuberculosis. Tolerated, with a lower risk of treatment continuation compared to traditional 600 milligrams. Regimens containing 400 milligrams and 600 milligrams are comparable for viral suppression. Efavirenz 400 milligrams is expected to be safe in pregnant women like 600 milligrams. Pharmacokinetic studies suggest that drug concentrations decline slightly with efavirenz 400 but remain within the therapeutic range. Efavirenz 400 milligrams can also be co-administered with rifampicin-containing TB treatment. However, WHO advises that efavirenz at either strength should not be used in situations where there are high levels of pre-treatment in an RTI drug resistance. Plus 3TC or efavirenz, the second-line regimen following first-line failure, should be tenofovir plus 3TC or FTC plus dolutegravir. And treatment adherence is a major challenge in all settings and across all populations, but especially pediatric and adolescent populations, postpartum women and men. Poor retention undermines program and patient outcomes, including achieving sustained viral suppression. WHO recommends that the mainstays of interventions to maximize retention in care are the provision of community-based support, including peer mobilization, adherence clubs, and differentiated service delivery. Retention in care. Let's look at some of the consequences of interrupted care. First is HIV-related hospital admissions. In this case, admissions to a district hospital in Cape Town in South Africa. Of 600 such admissions, 45% of those admitted had interrupted their care and their antiretrovirals, while 36% had never started treatment and 19% were on treatment and were failing. This emphasises the point that the most common reason for admission to the hospital in this study was not being retained in care and not on ART care. This time patients presenting with advanced disease to a hospital in DRC. Again, the majority of late presenters had stopped their ART for more than 3 months, with a smaller percentage never starting treatment and some who were failing. The authors of the study point out that this is an example of the changing face of HIV-related disease, with late presentation not due to not being on treatment, but indeed due to initiating and then stopping. Here's what peer mobilization looks like in the real world. This vendor in the largest market in East Africa, in Kampala, Uganda, is encouraging men to get tested and to start and stay on their treatment. Of a test and treat campaign, encouraging people in their communities to be tested and treated as early as possible by Médecins Sans Frontières, are now recommended by WHO as standard of care. In this model, groups meet either at the health facility or in the community and train peers to dispense drugs, measure weight, conduct symptom-based health assessment and adherence counselling. Once a year, a nurse takes blood from everyone for viral load assessment. People with problems go back to the clinic for further health assessments. In rural settings, one group member will attend the clinic every 6 months to collect ART for everyone. Is a package of services which includes less frequent clinic visits every 3 months, every 6 months, or even every 12 months, community ART pickups, multi-month refills of 3 to 6 months of supply of drugs rather than the traditional 1 month, and fast-track clinic visits where stable people can skip the queues just to pick up their drug and go. Or stable patients. WHO defines a stable patient as one who is on ART, has no adverse drug reactions that require regular monitoring, has no current illness or is not pregnant, not currently breastfeeding, has a good understanding of lifelong adherence and evidence of treatment success, such as viral load suppression or other markers. The 4 pillars of when, where, who, and what, aimed at simplifying the way that antiretrovirals are delivered in a people-centered manner in the context of lifelong treatment and increased self-management of people who are stable on ART. Can improve adherence. Work at both facility and community levels, delivering psychosocial support and education for pregnant women and new mothers. Mentor mothers track ART pickups and follow up with text messages and phone calls and home visits when mothers miss an appointment. One-on-one interaction with the client provides adherence assessment and tailored education. Evaluated and found to be associated with high rates of adherence. Almost 95% of mothers average more than 95% adherence to their ART over multiple assessments. Further, the evaluation reported that low levels of adherence were significantly associated with lack of male partner support and partner violence. More key concepts and wrap up the module on specific situations, namely people presenting with advanced disease and the initiation of treatment in key populations. WHO defines advanced disease as a CD4 count less than 200 if known, or WHO disease stage 3 or 4. The essential package of care for these people includes rapid initiation of ART, systematic screening for cryptococcal disease, and active screening and appropriate prophylaxis for tuberculosis and toxoplasmosis. Finally, those presenting for initiation of ART with advanced disease are at risk for both morbidity and mortality in the first 6 months of treatment, and they require more intensive follow-up during this time. Infections among adults worldwide occur among people from key populations and their immediate partners. Key populations living with HIV should have the same access to ART as other populations. All pregnant women from key populations should have the same access to services for the prevention of mother-to-child transmission as women in other populations. Finally, health services including ART should be made available, accessible and acceptable to key populations based on the principles of medical ethics, avoiding stigma, non-discrimination, and the rights to health. Module with a few questions. When should ART be initiated? What ART should be initiated? What measures have been demonstrated to improve retention and care? What interventions have been demonstrated to improve adherence? How does differentiated care improve adherence and retention in care? What are the 2 consequences of interruption of care and interruption of ART? What is the minimum package of services for people initiating ART with advanced disease?